Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Imagine this, a common household product, something you might have under your kitchen sink maybe, or even a drink you think is harmless, could rapidly turn deadly if mistakenly ingested. The clock starts ticking the moment it enters the body, and timely intervention isn't just important, it's literally the difference between life and permanent damage, or even death. We're talking about substances that can cause blindness, brain damage, kidney failure. Serious stuff. Okay, let's unpack this. Today, we're diving deep into the hidden dangers of toxic alcohols. While yes, all alcohols can be harmful if you drink too much, we're focusing on a specific kind of insidious subset, those compounds explicitly not meant for you to drink. This isn't just, an academic thing. It's about life-saving knowledge that everyone should probably be aware of.
Yeah, what's truly fascinating here is how these compounds, they often look and sometimes even smell similar to the ethanol we're more familiar with. But they behave so dramatically differently and dangerously inside the body. So this deep dive is really designed to clarify these distinctions. We'll look at their unique chemical properties, how your body tries to process them, and crucially, the severe, often delayed toxic effects they cause. We'll zero in on the big players: methanol, ethylene glycol, and isopropanol. And we'll touch on others like diethylene glycol and propylene glycol too. Basically, our mission is to equip you with the knowledge to understand how these poisonings happen, how they're recognized, and, well, what critical steps are taken to manage them.
Okay, so let's start with the absolute basics then. When we say toxic alcohols, what are we actually defining here?
Right. Put simply, we're talking about any alcohol other than ethanol, the kind in alcoholic drinks that is unequivocally not meant for you to ingest, period.
Chemically speaking, though, they're all alcohols. Hydrocarbons with that OH group.
Exactly. They all have that hydroxyl, the AOH group, attached to a hydrocarbon chain. Seems simple, but where that little group sits on the chain can make a world of difference, benign or, devastating. And understanding that structure really helps predict their behavior and toxicity. We can kind of group them. You have primary alcohols like methanol and ethanol, where the hydroxyl is right on the end carbon.
Got it.
Then secondary alcohols like isopropanol, rubbing alcohol, where it's on a middle carbon.
Okay.
We also have diols or glycols. These have two hydroxyl groups: ethylene glycol, propylene glycol. Those are the classics.
2 of 8 groups, right.
And finally, things like glycol ethers, like diethylene glycol. Basically, glycols with hydroxyl groups on a chain. Each difference in structure isn't just like a chemical detail. It really impacts how your body tries to break them down and the damage they cause.
That makes sense. So with that foundation, let's jump into the big 3 toxic alcohols. These are the ones that we really need to watch out for. First up is methanol, also known as wood alcohol, right?
That's the one. Clear, colorless, weak smell, kind of like ethanol. But don't let that fool you.
It's pretty sobering to think how common it is. Like windshield washer fluid, you said, that's over 60% of U.S. cases. That's huge.
It is. And model fuels, solid cooking fuel like sterno. It pops up in unexpected places.
And tragically, in illicit moonshine, too. That's a major global issue.
Absolutely.
Yeah.
And it's not just drinking it. People get exposed through inhalation like huffing carburetor cleaner.
Right.
Or even through the skin. There have been cases with methanol-soaked bandages used in some traditional remedies.
Wow. Okay. So it really is hiding in plain sight.
It is. And here's where it gets really interesting and scary with methanol. The alcohol itself only causes mild effects, maybe a bit of sedation.
So it's not the methanol itself that's the main problem.
Exactly. The true danger, the devastation, comes from what your body turns it into. Once it's inside, your enzymes, specifically alcohol dehydrogenase or ADH, start breaking it down. first to formaldehyde, which is nasty, but it's quickly converted again by aldehyde dehydrogenase, ALDH, into formic acid, or formate.
Formic acid, like ant stinks.
Sort of, yeah, same acid. But here, it's incredibly toxic. It directly attacks the mitochondria, the power plants in your cells. It inhibits a key enzyme, cytochrome oxidase. This messes up energy production and leads to a massive acid buildup in the blood, that anion gap metabolic acidosis we mentioned.
And our bodies just can't handle it.
Pretty much. Our natural way of dealing with it, using folate, just isn't sufficient. The human folate pools are too small to clear formic acid effectively, so it builds up and causes widespread damage.
And that explains the delayed effects, right?
Yeah.
The latent period.
Precisely. There's often this deceptive window, maybe 12 to 24 hours after ingestion, could even be up to 90 hours if they drank ethanol at the same time, which slows things down.
During that time, you might just feel a bit off.
Yeah.
Dizzy, stomach upset.
Exactly. But then, as that formic acid accumulates, the symptomatic phase hits hard. You get this severe anion gap metabolic acidosis, making people hyperventilate, trying desperately to blow off the acid.
And the vision problems.
Yeah.
That's characteristic.
Very characteristic. Blurry vision, this weird snowfield vision people describe. And tragically, it can lead to permanent blindness. You can see changes on the optic nerve.
Wow. And neurological damage, too.
Yes, severe damage to specific deep parts of the brain, the basal ganglia, especially the putamen. This can cause permanent movement disorders, almost like Parkinson's disease. It's truly insidious.
Okay, moving to the second big one. Ethylene glycol.
Right. Another clear, odorless liquid. But here's the really dangerous part.
Yeah.
It has a notably sweet taste.
Sweet. That sounds bad. Easy to mistake.
Very easy. And that sweetness is a huge factor in accidental poisonings, especially with kids, or even, sadly, in criminal cases. Its main use is as antifreeze in cars.
Ah, antifreeze, right.
But you also find it in degreasers, some household cleaners, even some cosmetics. That sweet taste just makes it incredibly risky.
So once it's ingested, does it act like methanol? Delayed toxicity from breakdown products.
Very similar mechanism, yes. The toxicity is driven by its metabolites. Ethylene glycol gets broken down, again by ADH and ALDH, through steps into glycolic acid. That's the main driver of the severe metabolic acidosis.
Okay, so acidosis again.
Yes, but then it goes further to oxalic acid, and this is particularly nasty. Oxalic acid combines with calcium in your body to form insoluble calcium oxalate crystals, little sharp crystals.
Crystals. Where do they end up?
Everywhere, but they especially clog up the kidneys. This directly leads to acute kidney failure. And because it uses up calcium, it can also cause dangerously low calcium levels in the blood, hypocalcemia.
So the clinical picture must reflect that kidney damage then.
It does. You can think of it like a 3-act play, though the stages definitely overlap. Stage 1, maybe the first 30 minutes to 12 hours. CNS depression, seems like alcohol intoxication, maybe some stomach upset.
Okay, like being drunk.
Right. Then stage 2, around 12 to 24 hours. Cardiopulmonary effects can kick in, heart problems, shock, lung injury like ARDS.
Serious stuff.
Very. And finally, stage 3, usually 24 to 72 hours. That's when the renal failure from the oxalate crystals really manifests. And unfortunately, even if people survive, some can have late neurological problems too.
Right, a grim picture.
Yeah.
Okay, let's talk about the third one, isopropanol. Rubbing alcohol.
Yep, isopropanol. Bitter taste, fruity odor, smells like acetone, actually.
And this one's everywhere too, right? Hand sanitizers, de-icers.
Absolutely ubiquitous. And it's actually the most frequent toxic alcohol exposure reported to U.S. poison control centers.
Really? More than the others?
Yeah, often used by people with alcohol use disorder as a cheap ethanol substitute.
Yeah.
And sadly, common in kids' accidental ingestion, or sometimes from sponge bathing for fever, it can be absorbed through the skin.
So with this one, is it the breakdown products again? Or is the alcohol itself the main issue? I remember you said it was different.
You got it. That's the crucial difference here. Isopropanol's metabolism is unique among these three. It is metabolized by ADH, but it gets turned into acetone.
Acetone, like nail polish remover.
Exactly. And here's the key. Because isopropanol is a secondary alcohol, it doesn't get further oxidized into a carboxylic acid like methanol or ethylene glycol do.
Ah, okay, so no acid buildup.
Precisely. The parent compound, the isopropanol itself, is the main cause of the CNS depression. And its metabolism leads to ketosis, the buildup of ketones like acetone, but without the severe metabolic acidosis. That's the hallmark.
So double the intoxication you said earlier.
Roughly, yeah. At similar levels, isopropanol is about twice as intoxicating as ethanol, so you get rapid, severe effects. Deep intoxication, coma, slowed breathing, low blood pressure. The acetone it forms also adds to that CNS depression, makes it last longer.
In stomach issues, too.
Definitely. Nausea, vomiting, sometimes even hemorrhagic gastritis, bleeding in the stomach lining.
Oh.
And metabolically, that key finding, ketosis without metabolic acidosis. Patients might even have a distinct, sweet, fruity breath odor from all the acetone.
Interesting. So those are the big three. You mentioned a couple of others briefly.
Right, just quickly. Propylene glycol. It's used as a solvent in many IV medications like phenytoin or lorazepam, also in some safer antifreezes.
Okay.
It gets metabolized to lactate, so it can cause lactic acidosis, but it's different. The lactate is a direct product of breaking down propylene glycol, not necessarily a sign the body's tissues aren't getting enough oxygen, which is what we usually think of with high lactate.
But it can still cause problems.
Yeah, it can still cause CNS depression if it accumulates, especially if kidney function isn't great.
And the other one was benzyl alcohol.
Yes, benzyl alcohol. That's more of a historical note, but a really important one about drug safety, specifically about excipients, the inactive ingredients. It used to be a preservative in IV solutions, but tragically it caused something called neonatal gasping syndrome in premature babies.
Oh, no.
Yeah, a devastating condition. Multi-organ failure, severe metabolic acidosis, often fatal. It led to major changes in how we formulate medications for newborns. A stark reminder to check all the ingredients.
Definitely. So with all these different effects, often delayed, how do doctors even figure out what's going on, especially if the person can't tell them what they ingested?
That's often the biggest challenge. Diagnosis can be really tough, especially with no clear history, or if ethanol was also ingested, masking or delaying things. Early recognition is absolutely key. You cannot wait for specific blood tests for these alcohols to come back. Those can take hours or days. Treatment needs to start based on suspicion.
So you rely on clues, like minding the gaps.
Exactly. We use indirect laboratory clues. One of the most important is the anion gap metabolic acidosis, AGMA.
Right, we mentioned that for methanol and ethylene glycol, the gap is the unmeasured toxic acids.
Precisely. Those toxic metabolites formate, glycolate, are anions that aren't normally measured in standard blood tests. So when they build up, they create a gap in the calculation. A high anion gap is a huge red flag for methanol or ethylene glycol poisoning.
But you said it takes time to develop.
It does. It might take 16, even 24 hours for methanol sometimes. So a normal anion gap early on doesn't rule it out. You need to measure it serially, watch for it to increase.
Okay. What about the osmolol gap? How does that fit in?
The osmolol gap is another piece of the puzzle, often useful earlier on. Think of osmolality as the concentration of dissolved particles in your blood. The parent alcohols themselves, methanol, ethylene glycol, isopropanol, are small molecules that add to this concentration.
So they make the blood thicker, osmotically speaking.
In a way, yes. We measure the osmolality and compare it to what we'd calculate based on standard things like sodium, glucose, and BUN. If the measured value is much higher than the calculated one, that difference is the osmolol gap. A big gap, say over 50, is highly suggestive of one of these alcohols being present.
So there's a catch, right?
There is. It's not perfectly specific. Other things can raise it. And crucially, there's this reciprocal relationship with the anion gap. Early on, when you have lots of the parent alcohol, the osmolol gap is high and the anion gap might still be normal. As the body metabolizes the alcohol into toxic acids, the parent alcohol level drops, so the osmolol gap falls, but the acid level rises, so the anion gap increases.
So someone presenting late might have a high anion gap but a normal osmolol gap?
Exactly, making interpretation tricky. You need to consider both gaps and the timing.
Got it. What about checking the ethanol level itself?
Absolutely critical because, as we touched on, ethanol competes for that same enzyme, ADH. If ADH is busy breaking down ethanol, it can't break down methanol or ethylene glycol into their toxic products. So ethanol is actually protective if ingested alongside a toxic alcohol.
So a high ethanol level makes toxic alcohol poisoning less likely to be the cause of, say, acidosis.
Generally, yes. If someone comes in intoxicated, looking drunk, but their ethanol level is 0 or very low, you have to look for another cause, like a toxic alcohol. An ethanol level above about 100 milli-GDL makes significant toxic metabolite formation pretty unlikely.
Okay. And lactate. You mentioned that can be tricky too.
Right. Lactate concentration. Methanol and ethylene glycol poisoning do cause a true rise in lactate because their metabolites disrupt normal energy production. But with ethylene glycol, there's that extra wrinkle. Glycolate, one of its breakdown products, can sometimes fool certain lab analyzers, making them report a falsely high lactate level.
Lactate gap.
Exactly. Something clinicians need to be aware of. Propylene glycol, on the other hand, causes a true high lactate because lactate is its main metabolite.
Are there other simple clues, like in a urine test?
Yes. Urinalysis can be helpful. For ethylene glycol, you might see those characteristic calcium oxalate crystals. They often look like little envelopes or spindles under the microscope.
And for methanol?
For methanol later on, brain imaging like CT or MRI might show those specific bilateral basal ganglia lesions, which are quite characteristic.
Okay, so diagnosis is a bit of detective work. Let's talk management. What's the first step?
Always the basics: resuscitation and supportive care. Airway, breathing, circulation, the ABCs. Patients might need oxygen, fluids for low blood pressure, maybe even intubation and a ventilator if they're in a coma or can't protect their airway.
And trying to get the poison out, like activated charcoal.
Gastrointestinal decontamination is rarely useful here. These alcohols get absorbed really fast, and charcoal doesn't bind them very well anyway, so usually not indicated.
So the main focus is stopping the body from making those toxic metabolites.
That's the cornerstone for methanol and ethylene glycol, yes. Inhibiting toxic metabolite formation by blocking that enzyme, alcohol dehydrogenase, ADH.
And the main way to do that now is flumpizole.
Correct. Flumpizole, brand name Antizol, is the preferred antidote in the U.S. and many other places. It's a potent, specific inhibitor of ADH. It effectively stops methanol from becoming formic acid and ethylene glycol from becoming glycolic and oxalic acid.
What are its advantages over, say, using ethanol?
Several big ones. Flumpizole reliably inhibits ADH without needing constant blood level monitoring. Crucially, it doesn't cause CNS depression or make the patient intoxicated, which ethanol does. It generally has fewer side effects. And there's evidence it might even reverse early visual impairment in methanol poisoning if given quickly.
So it's safer and easier to use.
Essentially, yes. It might even reduce overall hospital cost by potentially avoiding ICU stays needed for ethanol therapy monitoring. Just remember that crucial contraindication, not for isopropanol poisoning. Blocking ADH there just prolongs the isopropanol exposure and acetone formation, offering no benefit.
Right. But what if flumpizole isn't available? Is ethanol still used?
It is. Historically, it was the standard treatment, and it's still a viable option in resource-limited settings. The principle is that ADH has a much higher affinity for ethanol. It prefers ethanol. So if you keep the blood ethanol level high enough, the enzyme stays busy with ethanol and ignores the toxic alcohol.
But it has downsides.
Significant downsides. It requires admission to an ICU for close monitoring, frequent blood ethanol level checks because its metabolism is unpredictable. And it causes intoxication, CNS depression, which can worsen the patient's state. Plus, risks like low blood sugar, pancreatitis, gastritis. It's much more complicated to manage safely.
Okay, so blocking the enzyme is key. What about dealing with the acidosis that's already built up?
Good question. Correction of metabolic acidosis with bicarbonate is crucial.
Why does giving bicarbonate help beyond just neutralizing the acid?
It uses a principle called ion trapping. By making the blood more alkaline, less acidic, it shifts the chemical equilibrium of the toxic metabolites, like formic acid or glycolic acid. It favors their ionized form, which is less able to cross cell membranes and get into tissues like the brain and retina. It also helps the kidneys excrete them more effectively.
So it protects organs and helps clear the toxin.
Exactly. We treat aggressively if the pH is low, aiming for a pH above 7.2 low.
But it's not a cure on its own.
Definitely not. Bicarbonate is a vital bridge to definitive therapy, like dialysis. It doesn't remove the underlying toxin or stop its production. And for methanol, it must be used with an ADH inhibitor like flumpizole. Otherwise, the body just keeps making more formic acid and the acidosis becomes overwhelming or bicarbonate resistant.
Any risk with giving bicarbonate?
You need to watch calcium levels. If someone has low calcium, which can happen with ethylene glycol, rapidly correcting the acidosis with bicarbonate can sometimes trigger muscle spasms or tetany. So monitor electrolytes closely, and recommendations can differ slightly for less common toxic alcohols like diethylene glycol.
Okay, so if things are really bad, severe acidosis, organ damage, what's the definitive treatment?
Extracorporeal treatment, most commonly hemodialysis, that's the definitive therapy for severe poisoning.
How does dialysis help?
It's essentially an artificial kidney. It directly removes both the parent toxic alcohol and its toxic metabolites from the bloodstream. Plus, it corrects the acidosis and any electrolyte problems very effectively.
when would you definitely use dialysis?
Clear indications include severe metabolic acidosis that isn't responding well to bicarbonate and ADH blockade, any sign of end organ damage like coma, seizures, acute kidney injury, or vision loss, and very high measured levels of the toxic alcohol itself, though treatment is often started based on clinical grounds before levels are back.
Makes sense. Are there any other supportive treatments, cofactors or anything?
Yes, several adjunctive therapies. For methanol poisoning, we give folate, or more specifically, folinic acid, leucovorin. This helps the body metabolize and clear that toxic formic acid faster.
Okay.
For ethylene glycol, we often give thiamine, vitamin B1, and pyridoxine, vitamin B6. Theoretically, they help shunt one of the intermediate metabolites down less toxic pathways. The human evidence isn't super strong, but they're low risk, so generally recommended.
Anything else?
Well, corticosteroids are sometimes considered for methanol-induced optic neuropathy, the eye damage. Data is limited, but given the risk of permanent blindness, it's sometimes tried. And magnesium sulfate is often given with thiamine, as it's a cofactor for some enzymes involved in detoxification pathways.
Got it. What about specific groups, like pregnant women or children?
Good point. Pregnant women are a huge concern because these toxins readily cross the placenta. Untreated poisoning is devastating for both mother and fetus. Fompizole is generally preferred if available. Ethanol is an option if fompizole isn't, but it requires very careful risk-benefit discussion due to ethanol's own risks to the fetus. Breastfeeding should also be stopped temporarily during treatment.
And kids.
Children can get very sick from relatively small amounts just due to their smaller body size. The principles of treatment are similar to adults: ADH blockade, supportive care, dialysis if needed, but doses are adjusted for weight and you have to be extra vigilant.
Okay, this has been incredibly informative. Let's try to wrap this up. What are the absolute key takeaways for our listeners?
Right, so remember the big three: methanol, ethylene glycol, isopropanol, know their key features, methanol formic acid, acidosis plus blindness, ethylene glycol, band-glycol, glycolic acid, acidosis plus kidney failure, crystals, isopropanol, man-acetone, man-SCNS depression, plus ketosis without acidosis.
And diagnostically, mind the gaps. Anion gap and osmolol gap. Remember how they change over time.
Exactly. Treatment cornerstone for methanol-ethylene glycol is ADH blockade. Fompizole is preferred.
Bicarbonate is a crucial bridge for acidosis, and hemodialysis is the definitive treatment for severe cases.
And the most important message: don't delay treatment.
Yes. If you suspect toxic alcohol poisoning, especially in someone with unexplained severe metabolic acidosis and maybe low or zero ethanol, get medical help immediately.
Absolutely. Which leads to maybe a final thought. As we gain this deeper understanding of these chemicals, which are often just sitting around in our homes, what responsibility do we have? Not just to recognize the dangers, but maybe also to think about preventing misuse and accidental exposures in the first place.
That's a really important question to consider, something for all of us to think about. Stay vigilant, stay informed, and really appreciate that complex interplay between chemistry and our health. You've been listening to The Deep Dive. Thanks for joining us, and we'll catch you next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.